I would like to welcome and also introduce our first speaker, Dr. Wan. She's the Director Administrative Department of Pain Management Department, the secondary affiliated hospital of Guangzhou Medical University. She is also the leading scholar in the field of pain management and anesthesiologist in China with postdoctoral fellowship at the US University of Washington in St. Louis Medical School of Medicine. So her topic today is minimally invasive treatment for trigeminal neuralgia. And let's welcome Dr. Wan again. And Dr. Wan, you can now share your PowerPoint.
Okay, this time I will glad to share our experience about trigeminal neuralgia in our department use PBC procedure. So very honors for me to introduce the experience for our department. My topic is the minimally invasive procedure for trigeminal neuralgia. Trigeminal neuralgia, primary trigeminal neuralgia, is a common condition, mostly occurring in mid-age and elderly individuals over the age of 50. Its prevalence is 182 per 100,000 people, with an annual incidence of 4 to 5 per 100,000 people. The pain is typical, unilateral, excruciatingly severe, and patients often feel as tough life is unbearable. The incidence of the trigeminal neuralgia is different in the branches. There is data from the paper someone published. The incidence distribution across the branches of trigeminal neuralgia. The anatomy of trigeminal nerve, I will introduce it in here. The trigeminal nerve is somatic sensory fibers and somatic motor fibers distributed across the face, with motor nerves innervating the masticatory muscles. It composed of a large sensory root and a small motor root. The trigeminal ganglion is a crescent-shaped, located near the apex of the petrous part of the temporal bone, encapsulated within the slit between the two layers of dural matter. It's a Michael's cavity. Sometimes, if the catheter and balloon is put in the outside the Michael's cavity, it will show the like ball the shape. So we need to know the Michael's cavity is composed by the two-layer dural matter as the white side wall. The trigeminal nerve can divide it into three major branches: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. The etiology of trigeminal neuralgia is can divided the CNS etiology and the peripheral nervous system etiology. The CNS etiology include abnormal discharge, for example, the theory of epilepsy. The PNS etiology include mechanical compression or stretching of the trigeminal nerve roots caused by nearby vascular compression. The second is insufficient blood supply to the trigeminal nerve due to arterial sclerosis. the multiple sclerosis or spontaneous demyelinating lesions can also induce the trigeminal neuralgia. The also include the familial trigeminal neuralgia. The fifth is a theory of infection at a lesion or odontogenic lesion infection. Also include the single barbier and cranial base tumors, etc. The diagnosis and differential diagnosis, we confirm the symptoms of the patient happened appeared pain in the trigeminal nerve distribution, the paroxysmal lightning neck or needling prick neck, left cutting neck, and tearing neck pain in the trigeminal nerve dominated area, and sudden onset, lasting from several seconds to 2 minutes. Most of the patient is in this time course, but the serious patient may maintain for 2 or 3 hours. It can be triggered by talking, chewing, brushing teeth, washing face, etc. It's a normal neurological examination and has an interval period. In the interval period, the patient feels the normal and allow abnormal findings in neurologic and imaging examinations. Also, there are many the face pain happened should be mixed with mixed with trigeminal neuralgia. So we need to differentiation it. The toothache sometimes is not easy to distinguish. Typically, toothache is usually dull and something without clear episodic attacks or treatment. It may have brief period of severe exacerbation, often induced by chewing or stimuli from hot and cold foods. The second is cephalopalatine neuralgia. Its affected area is relatively large, with a positive cephalopalatine nerve block test. If the test is positive, then we can diagnose the patient as cephalopalatine neuralgia. The second is cluster headache. Cluster headache is occurring frequently over a period of time, accompanied by autonomic symptoms such as runny nose, tearing, redness in one eye, and eye swelling. It may shift to opposite side. Treatable with oxygen therapy, some tracting, and other treatments. The differential diagnosis also includes the cellulitis, atypical facial pain, and other disease such as multiple sclerosis and temporal mandibular joint dysfunction and tumors. Most in the clinic practice, many patients cellulitis also feel the pain, but the characteristic of the pain is different. Sometimes the patient cellulitis, the pain is dull and is not classic. The medications, carbamazepine is the first line medications, and its side effects are relatively common. The treatment, the trigeminal neuralgia treatment, always can include four methods. The first is percutaneous balloon compression. It also we would introduce today. The second is percutaneous radio frequency thermocoagulation of the semilunar ganglion. The third is craniotomy microvascular decompression, the MAD. Also the gamma left radial surgery. Here I will introduce our experience on the percutaneous balloon compression for TN. The efficacy should be very quickly relieve the pain, the 97.2%. The minimally invasive is slightly damaging, lower risk for doctor and patients. It's easy to learn and can be implemented in hospital at all levels. What's the PBC procedure? It's under imaging guidance. The puncture leader is inserted to the outer opening of the foramen alveolar. The stanet is removed and the balloon catheter is implanted to microcave. And imaging guidance, contrast agents slowly injected to make a balloon burst into an inverted pear shape toward the posterior fossa, then compressed for 90 to 180 seconds. After compression, the contrast agent is withdrawn, and the puncture leader and the balloon assembly are removed together to achieve the purpose of relieving trigeminal neuralgia. The background of the PBC treatment for TN. At first attempted balloon compression for treating trigeminal neuralgia by Mullen in 1978. The first case was reported in 1983. Trigeminal neuralgia, the first surgical indications is relatively restricted. Include a patient unsuitable for MAD, elderly and frail, poor general condition, low vascular compression detected on MRI. The second TN caused by multiple sclerosis, recurrence after MAD surgery or recurrence in patients who underwent different percutaneous procedures such as thermocoagulation of the TN. The current surgical indications include all trigeminal neuralgia patients, including those unsuitable for or unwilling to undergoing MAD surgery. The second TN patients, including those with multiple sclerosis and CPA tumors, but the tumors were not involving the microscope. But the contraindications, the surgical contraindications include patients with severe systemic disease who can't tolerate general anesthesia, patients with coagulation disorder, or those taking anticoagulants need to suspend anticoagulant use until coagulation function returns to normal. The patients with active infections involving the puncture pathway also include the active otitis media or mastoiditis. The patients with vascular lesions such as aneurysms, vascular malformations affecting the SYM side middle cranial fossa base, CPA, puncture pathways, or microscope, or with trigeminal schwannoma, meningioma involving the same side microscope. This is the microscope cavity, the anatomy. the cavity structure between the two layers of the dural matter. The microscope includes the anterior and the superior wall, the posterior wall, the lateral wall, and the anterior portion of the medial wall, and the anterior section of the inferior wall. The lateral wall is very important for our puncture the trigeminal neuralgia to the microcave. It has two layers of dural matters. The outer layer is formed by the intrinsic dural matters of the middle cranial fossa, where the inner layer is created by a refracting of the dural matter from the middle cranial fossa. This inner layer forms what is considered the true lateral wall of the Meckel's cavity. So sometimes if the catheter is put into the dural, the two layer of the dural, it cannot get to the microscope, cannot get successful the procedure effect. The foramen alveolar is a canal located at the root of the great vein of the sphenoid bone within the middle cranial fossa. At the root of the great vein, from front to back laterally, are the foramen rotundum, foramen alveolar, and foramen spilosum. These foramina transmitted maxillary nerve, mandibular nerve, and meningeal artery, respectively. Preparing pre-operative preparations, we should give the patient a screw-based precision X-ray. Should conduct it to understand the condition of the foramen alveolar, cranial CT for screw reconstruction, MRI with thin slice T2. Contrast the enhanced T1 to assess the size and shape of the foramen alveolar and the Meckel's cavity, excluding the vascular malformations, intracranial masses, and multiple sclerosis. If we will give the patient procedure, the patient always select the supine position, head slightly tilted back, shoulders slightly elevated, head squared within a headband or tapped on the forehead to prevent movement, head tilted back 10 to 15 degrees. The puncture point and the direction. The insertion point in intersections of the midline from the lateral coxus on the affected side and the extended line from the corner of the mouth. The depth should be kept inserted neither 6 centimeter, reaching below the foramen alveolar. Sagittal directions, the insert neither towards the intersections of the saddle base and clavus versus nice. Cannular leader shouldn't exceeding the interior opening of the foramen alveolar. Balloon catheter depths should be, the end marker should be within 5 millimeter outside the clavus line. Slowly injected contrast mediums into balloon to form an inverted pear shape. Below the cellar tussock near the clavus line, protruding towards the posterior fossa, compressing for 2 to 3 minutes, then evacuate the balloon and remove the puncture leader and balloon. There are 3 core elements for the successful PBC procedure. The compression time I introduced previously. In special cases, compression time can be extended accordingly. The balloon volume average is 0.5 to 0.7 millimeter. The maximal dose generally doesn't exceed in 1. This is intraoperative images. We can hear the maxillary, maxillar and the mandibular. Between them, here is the Freeman ovary. Here is the sagittal position. We can see the outside Freeman ovular. Here is show the inverted pear shape of the balloon. Is also the intraoperative image. Is a CT in guided surgery. The typical case is the inverted pear, also the tapitalis rockets, also the bony and the dark head shape. Pear-shaped imaging is very important. When the balloon is inflated in maker's cavity to a certain pressure, the tip of the balloon will protrude through the entrance of the maker's cavity into posterior cranial fossa, forming a reverse pear shape with the coda located posterior superiorly. When the balloon assumes this reverse pear shape, it indicated that the capacity of the maker's cavity matches the volume of the balloon. It can result in the successful procedure. This is our observation of the trigeminal neuralgia engaged in the PBC procedure and compared the traditionally cannot use the test the pressure. We use testing the balloon pressure. Then we got the result that average the compression pressure is 127.8 the kappa. The average pressure transfer the mmHg is 891.6 to 1025. But this is from the beginning, the pressure may be higher than if the patient previously received the radio frequency thermocoagulation procedure. Maybe the adhesion of the tissue. So we insert the catheter, then injection the balloon. Should be the pressure is higher. Here show the firstly the higher the pressure is 240 kappa. Then it's stable several minutes. Then the pressure stable keep the 126. This pressure is in this range, but this data unpublished. If the patient cannot get the satisfactory balloon, we should slowly withdraw the balloon catheter. If it gets stuck, simultaneously withdraw the puncture needle, then repeatedly flushing the catheter with saline, reinserted the guide wire into a catheter with the puncture needle slightly adjusting in a certain direction and reinsert toward the foramen alveolar, then place the balloon catheter. If a satisfactory balloon shape still cannot be achieved, redo it until the satisfactory balloon shape. If the balloon shape is satisfactory, the surgery can completed. The balloon catheter insert too deep. We can see here it's from the little drug contrast injection. Then we found when we give the more contrast drug, then the should next should be a deep. A little bit deep, so we just withdraw the balloon. Then should pear shape is a classic pear shape. Balloon is sometimes is not in the microscope, such as the epidural balloon. It's outside the microscope, inner or inferior side wall. So it can outside the microscope. Also, we can see the subdural space balloon. It's between the two layers of dural matter. A micro's nitral wall should like a ball. Balloon rupture, sometimes we also can meet. It's always induced by the incorrect puncture site or local tissue scarring and adhesion, fibrous ossification. Solution should be withdraw the catheter and replace a new one. Excessive resistance when inserting the catheter indicates an incorrect puncture site, requiring adjustment of the puncture angle. Is a balloon ruptured where inflation to a certain level? The cause can be local fibrous ossification. When reinserting the catheter, avoid ossified areas, starting with no pressure compression, extending compression duration, and gradually increase the pressure to normal level. Also, it here shows the yellow color area is safe zone, and the orange color area is the inner interjugular vein and the artery. So here is a dangerous place. Also, sometimes the ligament calcification should be disrupt over going on the catheter. The trigeminal ligament, trigeminal ligament. Sometimes our foramen calcification, the bone proliferation around our foramen obstructing the access. Sometimes we also can meet bleeding during puncture, but most of the venous plexus is a minimal bleeding. Cannot be very worried about it. But sometimes seldom can meet artery bleeding. Should be stop the procedure and sometimes need to apply local compression to reduce blood pressure, and also apply for the other department to help us to do the vessels treatment. Appropriate treatment is required according to the actual extent of the injury. PBC should be surgery can be considered again after 2 weeks stabilization. During surgery, there are some side effects: bleeding, autonomic nervous reflex, other cranial nerve injury complications. The post-surgery including sensory decline, weakness of the mastectory muscles, habits, diplopia. There is a comparison of treatment method is radio frequency, MVD, and PBC. For the MVD and PBC, their recurrence rate is almost the same, is 11% or 10%. But MVD may be more severe complications and also patient more dangerous. But PBC is relatively safe and also is very quick recovery the patients. The cost also lower for the PBC patients. Here is the summary of the surgical options for TN, the 3 methods, PBC, MVD, and RF. You can see here the surgery time, the PBC. Sometimes we do it very quickly. Sometimes 15 minutes, lower than the 30 minutes, and the MVD need 100 minutes, and the RF 6 minutes. Also, we can see the intracranial hemorrhage is very rare for PBC, and the RF is also very rare, but MVD relatively high. Okay, thank you. Okay, this time I will share with our experience here. Thank you for your attention.
Okay, thank you very much, Dr. Wang, for your very informative presentation. I think you covered, both theoretical but also practical tips and also informations. And I believe that all of us has gained the information that they want. So thank you very much for your time. Next part would be the introduction of SYM's Matreneu PBC kit. Let's welcome Elena. She's from SYM Medical team, and she will be sharing a brief introduction for this product. And actually, currently, it is the world only PBC kit with manometer and also with the indication of trigeminal neuralgia. So, Elena, please share your PowerPoint, and you can start.
Okay, next part is about our PBC case. The PBC case has several highlights. The first and the one and only the PBC case with a manometer. It ensures the precise and controlled procedure. It is widely used. It has been used in over 1,000 top class across China, with cumulative use more than 8,000 sites in clinical settings. It has proven its reliability and effectiveness. Additionally, the case has got the CE, MDR, and US FDA, meeting the highest international standards. The Matreneu PBC case is a dedicated case specialized design for the treating the trigeminal neuralgia. The PBC case will include the balloon caster, puncture needle size, and syringe connectors, and the manometer. The manometer was developed based on the neurosurgeon's idea, accurately monitor and control the internal pressure of the balloon caster, and featured with the on-off valve, managing the liquid flow, and with multi-measurement units like the KPA, ATM, and so on. It is a disposable product. The balloon caster with the exceptional elasticity of balloon, although it adapts to the the structure of macro curves, which enhance the efficiency of the procedure. It has the radio peak markers at the distal end. It is visible under the imaging equipment like the CT, OM, and so on. The balloon caster and the puncture needle size have their corresponding reference markers on them, and the first mark on the balloon caster means the seamless at the puncture needle, and the second marker between the first mark is the seamless with the balloon, and the third mark between the second mark with 1 centimeter. The surgeons should not go inside anymore. That means the last mark is a safety mark. As for puncture needle size, the hollow needle size, the size with the 13 gauge, 14 gauge, and 15 gauge. The blanched tips of stylet protects the vessel and the inner structure from accidental damage. The special markers on the puncture needle that give the reference of the nerves of the surgeons. The stylet facilitates a balloon by creating a pre-channel without the resistance to let the balloon go inside. There are 3 key elements for the PBC procedure. There are compression times, balloon shape, and balloon pressures. It should be well controlled, lead to a successful outcome in treating the trigeminal neuralgia, while it can minimize the facial numbness. And the duration of the compression time should be 90 seconds to 120 seconds. The balloon shape should be with a pear shape, conforming with the structure of the macro curve. It can ensures the comprehensive nerve compression. And as for the balloon compression, pressure with the 152 to 130 kPa. This pressure gauge ensures effective compression without causing the unnecessary side effects.
If you have any more questions or information that you require, you can send a query to info@symmedtech.com. It's our general email box that we will receive all the information from here. And here is the linking page. Maybe all of you can scan the QR code by your phone's browser, and then you can follow the information. Thank you very much. You have a nice day.